Hi, I'm Gulfo Zelos-Warnett, Assistant Professor in the Departments of Family Medicine and Psychiatry at the University of Michigan. And today I'll be covering the topic, opioid misuse among pregnant women. Opioid use during pregnancy is a significant public health concern, and it's also common. So recent data from national surveys have found that there's been dramatic increases in opioid use during pregnancy. In just over 1 decade of time, the prevalence rates have increased by 127%. Opioid use, which includes heroin use and prescription medication, is associated with significant risks for both the mother and the developing infant. Some of those birth outcomes include a cluster of symptoms which are known as neonatal abstinence syndrome. And this occurs when a baby withdraws from opioids when a mother uses them during pregnancy. In this graph, you can see this dramatic increase. So this is from a recent study that shows a 5-fold increase in the number of infants born with NAS in the United States. And this increase of NAS is thought to be associated with increases in prescription opioids that are given to pregnant women for pain. We know that NAS is associated with a number of negative consequences for the fetus and for the infant, including a lower birth weight, newborn intensive care unit increases in admissions. And additionally, when we think about global impact, we have growing hospital costs for treatment of NAS. Pregnancy is a window of opportunity, which is a very positive thing in that women during this phase of their life tend to be particularly motivated to make behavior changes because of the dual impact of themselves and their baby. And one way to engage women is using motivational interviewing, which is a client-centered approach to help with behavior change. And this can facilitate SBIRT, which is screening, brief intervention, and referral to treatment. SBIRT is recommended as part of comprehensive care, and screening is recommended universally for pregnant women. So that is that as early as the first prenatal visit, pregnant women can be asked about their drug use, and specifically about opioid use. It is not recommended to do drug screening universally. And the reason for that is that there tend to be higher costs for this screening, and also there tend to be false positive rates. And the concern there is that women themselves may have to face consequences because of their drug use in certain states, including legal consequences. SBIRT is found to improve maternal and infant outcomes in the context of pregnancy and postpartum. And it's important that we provide support services not only during the prenatal period, but also during postpartum period. And that can include contraceptive counseling because we can help reduce the risk of unwanted pregnancies. The standard of care, in addition to behavioral treatment, includes medication-assisted treatment. And the two well-known medications are methadone and buprenorphine. Up to 75% of infants born to women who are using methadone or buprenorphine can require the treatment for NAS. But the good news is that methadone and buprenorphine are associated with less severe withdrawal symptoms for babies. And they're also compatible with breastfeeding. That is, that methadone and buprenorphine, there's a very low level of it that is found in breast milk. There are a number of obstacles to consider when treating women, especially pregnant women who are using opioids. And one of those is the stigma that exists in the healthcare system. Because opioid use and drug use in general is a highly stigmatized behavior during pregnancy, it's important to be thoughtful about stigma and bias that might negatively impact care for these women. The lack of knowledge of screening instruments is also something to be mindful of. Not every provider receives training or feels comfortable using these screening instruments. There's also a lack of coverage for treatment. And we know that prenatal care is very important for outcomes, and the particular recommendation is the earlier the care, the better. There are also obstacles to consider, including threat of punishment or losing their child. So when it comes to specific states in our country, opioid use during pregnancy is considered a criminal act or even child abuse. And this is something that's a very real threat to some women and something to be mindful of. There are also associated risk factors of opioid use. For example, many women who misuse opioids are also at an increased risk of polysubstance use, and that is alcohol use and any other illicit drug. There are also co-occurring mental health conditions, including depression, and in fact, up to 40% of women who are enrolled in substance use treatment programs during pregnancy also struggle with depression and postpartum depression. Because of these risk factors, multidisciplinary care is the recommendation and the gold standard. And in particular, the postpartum period is a time of increased risk and vulnerability. We know that the use of opioids is greater postpartum than it is during pregnancy, and therefore the risk of overdose is also increased during this vulnerable time. And because of these reasons, it's important to be able to continue the services and care, including support groups and classes for these women. In summary, opioid use is a common problem among pregnant women, and it is associated with a great number of health consequences for the woman and for her infant, including neonatal abstinence syndrome. The recommendation in the standard of care includes medication-assisted treatment, including methadone and buprenorphine, along with behavioral treatment, such as individual therapy and a whole other segment of group therapy or support services during pregnancy and postpartum. It's important to be aware of the obstacles, including bias, stigma, and the threat of legal consequences, so that we can offer these women with appropriate treatment and prenatal care so that they can have the healthiest baby possible. Thank you very much for watching. I appreciate your attention, and I hope you learned something useful today.
My name is Philip Velez, and I'm an assistant research professor at the School of Nursing in the Applied Biostatistics Lab at the University of Michigan. I should also highlight that I've been a part of the core research group at the Women's Sports Foundation for nearly 10 years. My research focuses on adolescent sport participation and health, with a specific focus on substance use. I should also highlight that I am a sociologist by training. However, the majority of my work uses large-scale secondary data sets that assess outcomes related to health among various populations within the United States. In particular, youth athletes have been my primary focus over the past 10 years. My talk today is titled Opioid Use in the Athlete, and focuses on some of my research that explores the use of prescription painkillers within this large population in the U.S. I would like to begin with a little background on how I became interested in this topic. As a youth, I participated in multiple sports, particularly wrestling. While my participation in this sport clearly helped me develop social skills and push me forward academically, my exposure to this sport also brought me in close contact with a social network of peers who engaged in various types of alcohol, tobacco, and marijuana. Said in a more direct fashion, this sport introduced me to a group of athletes who taught me how to use different types of drugs. Ultimately, I eventually figured out how to use these drugs to help cope with the stress and pain I was experiencing from participating in a physically and mentally demanding sport. That was in 1996. Fast forward to 2012 when I moved to Ann Arbor as a postdoc to work with a group of researchers that were some of the first to examine prescription drug abuse. One of the topics being investigated was prescription opioid misuse. Given my interest in sports, it occurred to me that athletes should have higher rates of opioid misuse, given that they are more likely to deal with injuries and manage pain on a daily basis. When I first thought of this idea, I thought someone would have clearly investigated this topic. Keep in mind this was in 2012. Problematically, I could not find anything on this subject. When I saw the dearth of any research on this issue among athletes, I felt it was necessary to fill this gap. Having key sources of data that could address this topic, I dived into the data as both an objective researcher and a former athlete who already knew where to look. Maybe a good place to start is to have a brief discussion of what non-medical prescription opioid looks like among adolescents in the United States. First, the prescribing of opioid analgesics and non-medical use of prescription opioids have increased significantly among U.S. children and adolescents over the past 2 decades. However, these rates have declined substantially over the past few years. This is probably due to the attention focused on the harms of overprescribing opioids, along with healthcare professionals making serious efforts to change prescribing practices of this type of medication. Changes were clearly needed given that more than 1/3 of past year non-medical users of prescription opioids used leftover medications from their previous prescriptions. The slide on the screen gives an example of how rates of non-medical prescription opioid use has changed among adolescents since 1991. To help the audience with this presentation, 2 things need to be addressed as we walk through these slides. First, non-medical prescription opioid use refers to using opioids in a manner not Second, all data being presented comes from the Monitoring the Future, an annual survey that collects data on substance use among youth. As we can see, non-medical opioid use peaked in 2001 with roughly 1 out of 10 adolescents indicating non-medically using opioids. Fortunately, this rate has substantially declined to 3.4% in 2018. Rates of non-medical use of Vicodin and Oxycontin showed similar declines within the sample during this time frame. For instance, 9.6% of adolescents indicated non-medically using Vicodin in 2001. This has dropped to 1.7% in 2018. Given the heightened concern of non-medical prescription opioid use over the past decade, it is critical to assess out of 10 adolescents indicating non-medically using opioids. Fortunately, this rate has substantially declined to 3.4% in 2018. Rates of non-medical use of Vicodin and Oxycontin showed similar declines within the sample during this time frame. For instance, 9.6% of adolescents indicated non-medically using Vicodin in 2001. This has dropped to 1.7% in 2018. Given the heightened concern of non-medical prescription opioid use over the past decade, it is critical to assess athletes for several important reasons. First, youth athletes are more likely to sustain injuries when compared to their peers who do not participate in sport. Second, youth athletes may be more likely to receive and have leftover opioid medications due to sport-related injuries. This can be direct, namely, the athlete has surgery and receives opioids to manage pain, or this can be indirect. The athlete can receive diverted opioid medication from a teammate's leftover prescription. Keep in mind that leftover medication is one of the major sources of opioids that are used non-medically among adolescents. It should also be highlighted that certain types of athletes may be at greater risk of non-medical opioid use due to the level of contact or risk of injury embedded within the sport. Clearly, high-contact sports will put athletes at greater risk for injury. Additionally, it should also be stated that riskier adolescents are drawn to high-contact sports and may stimulate and reinforce a culture that values deviant forms of behavior like alcohol use, use of drugs for performance enhancement, and use of illicit substances to manage pain. Sociologists of sport refer to this as positive deviance, given that while it is deviant outside the context of sport, it is normative behavior within the sporting context. While male athletes may be at greater risk given the larger number of boys who participate in contact sports, girls are also at risk and may involve other sports that are not considered contact. For instance, collegiate female gymnasts have the highest injury rate and have the highest rate of prescription opioid use. In fact, the NCAA has found that female gymnasts have the highest rate of prescription opioid use at 17.7%. The next highest is men's lacrosse at 16.7%. In order to look at non-medical prescription opioid rates among youth athletes, we look at the data from the Monitoring the Future between 2006 and 2017. As we can see from this figure, both athletes and non-athletes had similar rates, which have both declined over this 12-year period. For instance, 6.7% of adolescents that participated in at least one competitive sport during the past year indicated non-medical prescription drug use in 2006. This dropped to 2% in 2017. In contrast, the next slide shows athletes in high-contact sports. Notably, all of these athletes' rates of non-medical prescription drug use were above the average across the 12-year study period until 2010. Since 2010, all of the athletes in these sports have rates of use below the average. For instance, 10.3% of wrestlers indicated non-medically using prescription opioids during the past year in 2006. This dropped to 5.2% in 2017. The next slide simply shows rates of non-medical prescription opioid use among athletes in non-contact sports. Two things to note is that rates of non-medical prescription drug use are lower, but still show a substantial decline during this 12-year period. In summary, it should be noted that athletes in high-contact sports typically have higher rates of non-medical prescription drug use when compared to adolescents in general, and have higher rates when compared to other athletes who participate in non-contact sports. However, it should be emphasized that these rates have declined substantially since 2010 among all athletes and non-athletes. While we have seen declines in prescription opioid use over the past few years, new concerns have been raised regarding recent increases in trends of other types of opioid misuse, like heroin. Given the reduction in the number of opioids being prescribed, people who are addicted to these drugs may be turning to other sources. While the media has been quick to see if athletes have been turning to heroin as a substitute for prescription opioids, data sources like the Modern the Future can shed light on which sports may be the greatest risk of both non-medical prescription opioid use and heroin use. Looking at the data, we see that adolescents who participate in high-contact sports have the highest lifetime rates of non-medical prescription drug use. For instance, 19.9% of wrestlers have indicated non-medically using opioids at some point during their lifetime. This is well above the average, which is 12.7%. The next slide shows rates of lifetime heroin use. Similar to the previous slide, high-contact sports have the highest rates. For instance, 4.7% of adolescents in ice hockey have indicated using heroin during their lifetime. Again, this is well above the average of all 12th graders. Overall, the data does show some evidence that certain types of athletes may be at greater risk for other types of opioid use. Problematically, most surveys focusing on drug use do not measure the full range of opioids that adolescents may use as a substitute for prescription painkillers. For instance, large-scale surveys do not measure fentanyl use, which is problematic due to this drug being linked to the spike in opioid-related overdoses over the past few years. To summarize, findings clearly demonstrate that athletes in high-contact sports are at the greatest risk for opioid misuse. This could be a combination of these types of sports being linked to greater injury, along with prompting a culture that may legitimize using substances to play through pain. Additionally, it cannot be forgotten that these rates of non-medical prescription opioid use have plummeted across all types of athletes since 2010. The decline in these rates is more than likely attributed to changes in prescribing practices and greater awareness of the risk of misused opioids. Finally, it should be recognized that other types of drug use may be replacing opioids in order to manage pain. In particular, we need to shift our focus to other types of substances like medical marijuana and other types of prescription drugs like sedatives or tranquilizers. In order to continue to make progress on reducing opioid misuse, we need to shift our focus to other types of substances like medical marijuana and other types of prescription drugs like sedatives or tranquilizers. In order to continue to make progress on reducing opioid misuse, effective interventions need to be put into place that target parents, given that they should be managing their children's medications. Certain interventions that inform parents about how to properly use and dispose of prescription opioids have been found to be effective in improving parents' knowledge and proper storage of these types of drugs as they relate to their children. Finally, more candid conversations among coaches and sports organizations regarding both substance use and opioid use among athletes need to take place. Open forums to discuss drug use among athletes need to take place within the school and community in order to bring greater awareness and foster attitudes to help athletes seek substance use treatment if they need it. With respect for next steps for research and practice, We need to do more research on the appropriate medical use of opioids among youth. No large-scale studies assess appropriate medical use of opioids among athletes. Namely, we do not have national estimates of prescribing rates among youth athletes within the general population. Additionally, Berry research independent of the NCAA has assessed opioid use among college athletes. Given that this is a more challenging population to assess, greater efforts by researchers is needed to assess this unique population. Finally, more global interventions that target youth in high-contact sports are needed at the interscholastic level to raise awareness on the risk on prescription drug abuse. This also includes the quickly growing private youth sport organizations that many adolescents participate in throughout the year.
My name is Mark Hilgen, and I'm a professor of psychiatry at the University of Michigan, also a researcher with the Ann Arbor VA. And today I'm going to be talking about the overlap between chronic pain and substance use disorders. And this is a topic that I've been interested in since I was wrapping up my training. I'm a psychologist, and in my last year of graduate school, I worked in a VA drug and alcohol treatment program. And at the time, the message that you heard from clinicians and also kind of out there in the general public was the idea that chronic pain was actually protective for the development of a substance use disorder. So what you heard is people would say, if you have a legitimate pain condition, you're very, very unlikely to develop any sort of symptoms of addiction. And I was working in an addiction treatment program where everyone pretty much by definition had a substance use disorder, and many patients seemed to be also struggling with chronic pain. So we had patients with amputations, patients with spinal cord injury, and I was trying to reconcile what I saw in front of me with this message that was out there in the general community. So for my clinical work as well as research, I wanted to understand the extent of overlap between chronic pain and substance use disorders, how common do these two conditions co-occur, and then what can be done about them. That was all around the early 2000s, and since that time, we've had the growth of attention being paid to the opioid epidemic, as well as the legalization of cannabis, first for medical reasons and now for recreational reasons. For cannabis, you often hear that medical cannabis use relates to the management of chronic pain. So all of these kind of larger cultural phenomena overlap with chronic pain and addiction, and it's that group with both pain and addiction that are most directly affected by some of these societal changes, and that's been the focus of my work. So to start with some basic questions, do chronic pain and addiction overlap? The answer from epidemiologic studies is yes. So if you look at survey data, if someone has a drug or alcohol problem, they're much more likely to have a chronic pain condition and vice versa. We did some work just looking at the VA's electronic medical record in all patients who use VA services and found that if you looked at people diagnosed with a drug or alcohol problem, over 44% were also diagnosed with arthritis, around a third were diagnosed with back pain, and when you look at the information in parentheses there, the odds ratio, having a substance use disorder increased someone's likelihood for being diagnosed with a pain condition from about 1.5 times to 2 times more likely to have a pain condition if they had the substance use disorder. It's not on this slide, but people have done the reverse of that set of analyses, looking at the extent to which a pain condition increases the likelihood of a substance use disorder, and a similar pattern emerges. Having one makes you more likely to have the other condition. Why is that? Why might these two conditions overlap with one another? This figure is what's called the fear avoidance model of chronic pain. This is a theoretical model for understanding chronic pain that's been around for close to 4 decades now. And what I've done here is just inserted the topic of substance use and substance use disorders into this figure where it might fit. The idea behind this is that understanding who goes on to develop chronic pain from an acute injury often has very little to do with the specifics of the acute injury and much more to do with how the person interprets their pain and copes with their pain. So the circular part of this figure is meant to capture the chronic pain spiral that someone can find themselves into, and the U-shaped portion is a path out of that. Just to go through this quickly, what you see is that an injury occurs and that leads to the experience of pain, but it's really how that pain is interpreted and how people adapt to it that matters. So if someone interprets pain as catastrophic, the sort of thing they can't really cope well with, if they avoid activities, and if they start to feel worse because they're avoiding not just the physical part of those activities, but also the social parts, withdrawing from their social environment, maybe going out less, talking to people less, going into work less, they then can function worse, but also experience pain. So they actually become more sensitive to the pain. They describe the pain as more severe, and then it's easy for them to interpret it as catastrophic, and you can see how that cycle repeats itself. What we've done here is insert where substance use comes in, and you can see how substance use can be a way of avoiding engaging in life, and if you do that over too long a period of time, you can develop a substance use disorder. As a pathway out of this cycle, you can see that this often involves thinking about the pain differently, interpreting it differently, and then actually engaging and confronting the pain or engaging in activities that are more rewarding. So obvious examples of this would be physical therapy. Instead of using an injured area less, using it more through strategic choice of exercises can get people more engaged in life. They feel better physically, and they also feel better psychiatrically. And it's our theory that can then lead to reduced substance use. So what does this mean clinically? First of all, because these two conditions co-occur, chronic pain is common in addiction treatment programs, and the reverse is true. In pain treatment programs, substance use disorders are common. If you look within the addiction world, which is where I work, the rates of comorbidity are, you'll see estimates ranging from 30% to upwards of 80% of people in addiction treatment reporting some form of chronic pain. When chronic pain is present, it tends to predict worse treatment outcomes. And this is true for functional outcomes. People feel worse following addiction treatment, but they actually have worse substance-related outcomes. The study I'm citing here is a 1-year follow-up of individuals entering a large addiction treatment program, and they found that people whose pain persisted following treatment were more likely to drop out of treatment and less likely to be abstinent than those without pain. So all of this points to the potential to improve the way we think about and treat pain during addiction treatment, and that this could lead to broader functional and substance-related outcomes in individuals with substance use disorders. So the next few slides I'm going to talk a little bit about specific studies we've done. This study is a randomized trial of patients recruited from a VA drug and alcohol treatment program. We recruited 130 patients. We randomized them to either get an intervention that focuses on pain, what we call cognitive behavioral therapy intervention or CBT intervention that helps people behaviorally cope with pain better without using substances, or they would get an enhanced treatment as usual control condition. We followed people for up to a year and overlaid this study on top of standard addiction treatment. Our study had relatively high follow-up rates. You can see up to a year following the baseline portion of the study, 84% of people we initially recruited were available to provide follow-up data, which for us was striking, given the fact that a lot of these folks were still were coming from chaotic environments. Many were homeless when they started treatment, so following them and staying in contact with them is challenging. So what did our outcomes look like? I'm going to go through these pretty quickly, but the comparisons are between the green bar you're seeing there, which is the intervention condition, and the grayish bar that is the control condition. This is a rating of pain level. How much pain does someone experience? What you can see is the intervention condition over the course of the year reports less pain than individuals in the control condition. This is a measure of pain-related functioning. How well is someone doing? And here, people in the intervention condition, on average, report higher functioning, generally doing better than those in the control condition up to 12 months post-baseline. When you look at substance use, this is a measure of number of days of alcohol use. So for this population who are recruited from addiction treatment, we'd prefer to see fewer days of alcohol use. And you see that the groups are pretty consistent or similar to one another at 3 months, but the control condition trends upward. They kind of go back to where they were at baseline with more days of alcohol use, and the intervention condition stays low and maintains the gains that they made early on in treatment. When we look at specific drugs of abuse, we don't see significant differences between conditions. And there are a number of potential reasons for this. We think that the main reason is that we had kind of imprecise measurement of drug use in this sample, and that's consistent with the wide error bars, or kind of the amount of noise we had in measuring both of these outcomes. And either way, no matter what caused this finding, we did not see any significant differences between conditions over the year post-treatment. One final outcome slide for this study. This is a measure of self-efficacy or confidence in the ability to manage pain without relying on substances. And on this measure, you see that the CBT condition consistently outperforms the control condition. And we think this is important because this points to what might be one of the key active ingredients of the intervention, where people feel better about coping with their pain without relying on drugs of abuse, and that this is the sort of thing that could be sustained over time and help people do better over the long run. So just to summarize this study, we feel that it provides initial support for the idea that having some form of behavioral pain management could improve drug or alcohol-related outcomes for patients seeking addiction treatment. Historically, when patients reported pain in addiction treatment, they were told that because a lot of medications for the treatment of pain could potentially be abused, that there wasn't really much that could be done to help them cope with their pain. So we think that this set of findings and then future work in this area could help change that narrative and help addiction treatment providers to have more of a positive way of talking about pain and engaging patients with pain when they show up to addiction treatment. That said, the slides you saw were just really one study. It's from the VA, so it's mostly male, and has definitely needs to be replicated. We have a study we recently completed that we're in the process of doing data analysis for that would replicate this in a larger community-based sample. And we actually have 2 new studies that were funded by the NIH to look at this type of behavioral pain management intervention in patients receiving Suboxone or opioid agonist treatment, medication-assisted treatment for an opioid use disorder, to see if some of the findings would hold for that important group of people with opioid-related problems. More broadly, our goal for this line of work is to better understand who with addiction is more likely to develop pain and who with pain is more likely to develop addiction. And then when those 2 conditions co-occur, what can we do to help people have better outcomes, live more fulfilling lives when they have both of those conditions going on together. So I'll end just by acknowledging that this work was funded by the National Institute of Health, so NIDA in particular, as well as with research funding from the VA. In terms of conflict, I'm part of a small company that's developing a wearable alcohol sensor called ArborSense. I don't think that relates to the work that I present today, but I want you to be aware of that. And I have no other conflicts of interest to report. Thanks for listening today, and I hope it was helpful.